陈赞声音没开开。
Sorry. Before we give a reasonable classification of C1C2 dislocation, we should know something about the reason why C1C2 can dislocated. First, we know that some trauma may lead to the dislocation between C1 and C2, like type 2 odontoid fracture. Also, some congenital disease, such as Down's syndrome or orthodontoid or occipitalization of atlas is a common disease. The patient may suffer the C1 C2 dislocation. Also, some inflammatory disease, such as rheumatoid arthritis, may lead to C1 C2 dislocation. Among all of these reasons, we find a very unique reason for C1 C2 dislocation, that is occipitalization of atlas. For you can see that all of other reasons like trauma, orthodontoid, or rheumatoid arthritis, all of these reasons destroyed the central part of between C1 and C2. They dislocated Atlanto-odontoid joint. At there is a dislocation in the central part, and accordingly, the lateral facet joint will dislocate together. But the occipitalization of atlas, this will lead the facet joint deformed, and the deformed, that means something wrong with the bilateral part of the between C1 and C2, and the deformed facet joint will lead the central part dislocated. So the reasons, the occipitalization of atlas is a very unique reason for C1 C2 dislocation. On the understanding of the reasons, I divided C1 C2 dislocation into two types, Type A and Type B. In Type A, the C1 C2 dislocation without basal invagination. In Type B, the Atlanto dislocation accompanied with basal invagination. Our strategy for Type 1 C1 C2 dislocation is a Goel's technique. For this kind of dislocation, we only need to reduce the transverse dislocation between C1 and C2. And we release the facet joint on bilateral side and plant screws in C1 and C2 and perform posterior fixation. We can get sufficient reduction of the dislocation. There did some complex case in Type 1 C1 C2 dislocation. For this is another case of odontoid, but on the facet joint, we can see there is a lot of deformity in the bilateral facet joint. So for this kind of a little complex case, we should release the facet joint profounded, and we plant a very small cage in the facet joint. We will get a more stable reduction and more solid bone fusion on bilateral side. So compare with pre and post operation CT scan, we can see that we get a very satisfied reduction between C1 and C2. Compare the MRI before and post operation, we can see the spinal cord are decompressed totally. Our strategy for Type B C1 C2 dislocation, it will be a more complex surgery. For this kind of patient, first we should push the C2 downward to reduce the vertical dislocation between C1 and C2, and then we should reduce the transverse dislocation between C1 and C2. Finally, we can get a total reduction for this kind of patient. So we use distraction cantilever reduction technique that we called this technique. It means that first we distract between C1 and C2 in the facet joint, and after the distraction, the facet joint to enough large space, we plant a cage with a suitable height in the facet joint, and then we implant the instrumentation, and with the cantilever technique, we reduct the transverse dislocation between C1 and C2. There did some difficult to separate the facet joint because the facet joint are always deformed and they locked together. And the second, there's a lot of ligament and muscle anterior at the C1 C2, and we call it anterior tendon band. And this soft tissue connected C1 C2 tightly together. So it's very hard to release the facet joint from posterior. But we can separate the facet joint. We can release from posterior, release the anterior tendon band. First, we distract between the facet joint, and by this technique, we release anterior tendon band, and then we plant the cage in the facet joint to keep the facet joint enlarged space. I designed some surgery tools for this procedure. This is some distractor between the facet joint, and this is a trailer of different size for the facet joint. And this is intraoperative CT scan. We can see the distractor and the trailer in the facet joint. And I also designed some special intraarticular cage for the facet joint, and a kind of compression occipital plate for the cantilever technique. And I put these tools together, and we call it Xuanwu CVG reduction fixation system. Less of complications. Thank you for your attention. Any comments?
Or any question? Dr. Jalali, do you have any question or comment?
Hello? Yes, hi.
Yes, please.
Yes, my question is, you end up doing probably more occipital fixation than you probably need in most of the cases. But as I understood, as you said in the beginning, most of your cases has C1 assimilation, right?
Yeah.
But if
most
this
of
is
our
not
cases
the
are
case,
C1 assimilation.
Yeah, but if this is not the case, C1, C2 is enough. Okay. This is your understanding?
Yes. If there is no C1 assimilation, I will do C1, C2 internal fixation.
Okay. No, congratulations. Very nice technique.
Thank you.
Okay, thank you.